Dr. Finitsis from Thessaloniki. Show us your experience.
Okay, good afternoon. It's a pleasure to be here. I would like to thank the organizing committee for inviting me. So I work in Thessaloniki. I work at the University Hospital, and we are the only public hospital who is providing thrombectomy. So we are on call every 4 days, and we try to persuade the administration to give us the people to be able, the doctors are there, but we need nurses, we need staff to be able to cover at least more than half of the time the entire city. For the time being, we're doing 1 or 2 thrombectomies per call, but I think eventually in the future we're going to scale up. So what I'm going to present to you is a work we did with the ETIS French registry. So for those who are not familiar, the ETIS is a big multi-center registry. Everything that happens in France goes into this registry. We are happy to work with these guys. And so actually we did a retrospective analysis of their cases, and we look at the complications in anterior circulation thrombectomies, the incidence, the predictors, and the clinical impact of these complications. So we all know that, of course, thrombectomy is a very efficient and relatively very safe procedure, but we still wanted to describe the prevalence of the different complications, their rate, their clinical impact, with the ultimate goal being to optimize thrombectomy procedures. So we took up the cases from January 2015 to May 2020, a total of 4,029 patients, anterior circulation strokes, M1 occlusions, M2 occlusions, ICA, and tandem occlusions. These were treated with any available technique, stent retrievers, aspiration, dual thrombectomy, and IV thrombolysis was administered if indicated according to the international guidelines. With IV thrombolysis, they used Alteplas 0.9 milligram per kilogram. So the complication we looked for were emboli to new territory, when you have thrombus fragmentation and you have a small piece that's going somewhere else than the initial territory. Vessel perforation, when you see contrast extravasation during the procedure, arterial dissection, and severe vasospasm. And the outcome variables were early neurological improvement, which is defined as a drop of NHS more than 4 points at 24 hours, and a good functional outcome, meaning MRS-02 at 90 days, excellent outcome, MRS-01 at 80 days, and mortality. So this is a case of arterial vasospasm, a typical M1 occlusion. We go in there, we do the thrombectomy, the vessel open up, but as you can see, Hopla. Oops. No. Okay, okay. And the pointer is this one, no? Okay, and as you can see, there is this small vasospasm, relatively moderate vasospasm afterwards. And if you do an MRI 24 hours later, everything is okay. So surprisingly enough, in the ETIS registry, we had serious vasospasm only in 2% of cases, while in other registries, they had 3.9 in the Revascat trial and 23% in the TRACE trial. And we think this has to do with the way you grade vasospasm. If you're very severe and you're grading and you think that only when you have very severe vasospasm, then you record it or not. But anyway, what we found is that it doesn't have to do with the way you treat it. I mean, you can just leave it or you can use vasodilators. Anyway, usually vasospasm, even when serious, doesn't have any clinical consequence. The patients who have severe vasospasm, they fare the same as the other ones. So vessel perforation, here we have an 89-year-old man admitted to the emergency department for syncope. He had acute onset aphasia and right-sided weakness. No RTPA was administered. And the CTA showed acute left ICA terminus clot. So he was brought to the angio suite. He was within the window. Aspect was okay. And we see he has the classical tip of ICA occlusion. First thrombectomy pass, we open the ICA, however, the M1 still stays closed. Then we do another thrombectomy with a stent retriever, and no success. Then we go up with aspiration catheter. We're thinking we are in a good position because it looks like the catheter looks exactly at the thrombus. We start aspirating, we do a control, and we see this extravasation into the sylvian fissure. And of course, what to do? We just waited, as I understand most of you would have done. Others would have put a coil just to lower the blood pressure, or others would have taken a balloon. But anyway, we were lucky. And on the next run we did, the hemorrhage has stopped. And eventually, the next day, the patient has a slight subarachnoid hemorrhage in the left sylvian fissure, and he did okay. So we were lucky, but most of the patients...
Just one question. You had the branch occluded.
Yeah.
Would you ever consider continuing or not?
No, I think we were so much afraid we just stopped.
Okay.
And we were lucky, and we were very happy that it stopped. I don't know what others would have done, but would have done.
Would anyone continue or no? Of course.
Okay, so perforations, they happened. About 1.7% in 4,000 patients had perforation. And when they happen, they have a very poor prognosis. About 40% of patients will die. And 2/3, about 75% of patients will have an unfavorable outcome. Now, predictors, we saw that statistically perforations were associated with occlusions, tandem occlusions, and carotid terminus occlusions. And we suspect this has to do, you have a large vessel, probably you have a large thrombus, and probably you're doing a lot of manipulation to get the thrombus out. And maybe this is the reason why these occlusion sites are associated with perforations. We also looked for the other complication, emboli to new territory. For example, here we have a patient that's coming in, who came in, and he has this MCA occlusion. He already has quite a few ischemic lesions in the right MCA territory. He's taken to the angio suite. He has this M1, M2 occlusion. It's done, the thrombectomy is done with a stent retriever. This was early days, and he had this small fragment who went into the right A2 segment, occluded it, and at that time we preferred not to do anything. And the final result is that in addition to the right MCA ischemia, he also has an anterior cerebral artery ischemia. So the patient went worse.
But what do you think? How to prevent this complication, which is really one of the worst that we have?
Yeah, I mean, this is one of the main challenges now. So if you look at the companies, they all try to make their devices better. They try to have larger catheters. They try to have better designs for the stent retrievers. So, I mean, from a material standpoint, they're trying to have this these enhancements. Now, technically, what we saw is that there's no difference in the prevalence of emboli to new territory if you use a stent or an aspiration or a dual technique. It's the same. So.
Sorry, what about a balloon guide catheter in the neck?
Balloon guide catheter, yeah. I know that there are publications that say that you have less less ENTs. But in this analysis, we put this variable and it didn't make any difference. So I know, I mean, you have differences between centers. Okay, so ENTs, I mean, emboli to new territory complications occur in 5.2% of patients. These are the most prevalent complications. And again, you see them more often when you have a tandem or carotid terminus occlusion, most probably because, again, you have a large thrombus and you try to take it out and maybe you create some small pieces. It's also attributed to the number of passes. The more passes, the more times you try to take it out, obviously, you will fragment the thrombus. And there doesn't IVT, previous thrombolysis, doesn't seem to have any bad or good effect on this. It doesn't change the prevalence of emboli to new territory. And dissection, and we mainly looked at the cervical dissection. For example, here you have this young, relatively young patient. He has an M1, right M1 occlusion. And you put your catheter, and most of the time you're quite aggressive because you want to take the clot out, and you do your control, and you see that you provoked a dissection of the ICA. And in this case, it was stented. And what we saw is that dissections happen. It happens in 1.5% of thrombectomies. Surprisingly enough, they don't have any clinical impact. So it looks like if you see a dissection that doesn't have a big hemodynamic consequence, then you probably can leave it as it is. Of course, if you have occluded the vessel, it's better to put a stent. But finally, if you manage it correctly, it doesn't seem to have any clinical impact on patients. And what was really a surprise is that you see more dissections in young patients without any comorbidities. And it looks like probably it has to do something with the endothelium, the young endothelium. Maybe it's more reactive. Maybe when you go with a catheter and try pushing, maybe you have higher chances to provoke a dissection. And it was also attributed with the use of stent retrievers.
How do you explain that? Because when you are pulling the retriever, you are going downwards. So, and we are taught that you are creating the section by going upwards, and then you're creating a channel through the intimal flap. So how do you explain when you're going downwards with the stent retriever that you are causing this section?
I'm not quite sure it has to do with the fact that you take the stent retriever out. I think it has to do with the way you manipulate your guiding catheter.
I agree. Yes, and while you pull your stent retriever, your catheter goes up.
Goes up, yeah.
So that's how sometimes the way you dissect the artery.
Okay, and if you look at the clinical repercussions, you see that when you don't have complications, you usually have this distribution of MRS. Here you have the mortality with deep blue, and here you have the patients who do well. Of course, when you have a perforation, you have a big mortality, somehow smaller, but not that much smaller when you have emboli to new territory. And also, when you have a dissection, there's also a slightly elevated mortality, but more or less the patients are doing well. So another complication that you may see after you do the thrombectomy is subarachnoid hemorrhage. We saw that in 4.6% in the ATIS registry, which goes along with a meta-analysis that found it in 6.26% of patients. So it looks like when you aspirate a thrombus and when you retrieve it with a stent retriever, you probably, that's the theory, you probably also cause rupture of small perforators or small venules, and probably these are at the origin of what you see after the thrombectomy, a small subarachnoid hemorrhage, which usually is benign. However, it is known that about in 2% of patients, you can experience a neurological decline because of this subarachnoid hemorrhage. And something that is not really correlated with the thrombectomy act per se is the hyperdensities you may see on 24 hours CT scan, which are you see it quite often. So these may be either to contrast staining because you have a disruption of the blood-brain barrier, And usually when it's due to contrast, these get reabsorbed in 24 to 48 hours, or it can be due to hemorrhage. And hemorrhage usually is less dense than contrast, and you can, if you have questions, you can sort things out with dual energy CT and MRI. And of course, you can use the Heidelberg classification. H1 is when you have a small petechial hemorrhage, H2 when it's somehow larger, PH1, frank intraparenchymal hematoma, less than 30% the infarct area, PH2, more than 30%. And you also have this notion, this concept of symptomatic intracerebral hemorrhage, which may happen with any type of hemorrhage, either it's H1 or PH2 or subarachnoid hemorrhage, that results in a 4-point increase in NIHS after 24 hours is characterized as a symptomatic intracerebral hemorrhage. Here, of course, you can do the MRI, see better if you have a hemorrhage or contrast extravasation. And if you look at the results of the ETIS registry, as I said, you have subarachnoid hemorrhage in 4.6% and PH1 and PH2 hemorrhages in 8% each, more or less. You have a high percentage of H1, H2, but these are most likely due also to contrast staining, so I wouldn't trust these numbers for these small hemorrhages. But you can see from the outcome table, here are the patients without any hemorrhage, and as the hemorrhage is more grave, you see that the mortality goes up and the percentage of patients who are doing well goes down. So we also did this, and I'm finishing with that, with this paper to see about the predictors of hemorrhage at 24 hours, and we saw that it is related to systolic blood pressure at presentation, diabetes, blood glucose, NHS, aspects, initial imaging with CT. It looks like when you do a CT, you underestimate probably the infarct area, the number of passes, and the time from onset to perfusion, and we calculated this curve that shows the contrary of the other curve with a good outcome who goes downwards. Here it shows definitely that as time goes by, the probability of having a hemorrhage goes up. Thank you very much.